So, hi, I'm so excited to be here, apart from anything else, because I've been working with people with MND for 20 years, and there's still faces there that I have known from 20 years ago. So that's absolutely fantastic. And just to let you know, all the way through, there will be a tartan theme, but unfortunately, I don't have my tartan dress on because it won't fit at the moment. All the ladies out there know exactly what I mean. So I read about breath-stacking by Alison Armstrong, and I don't know if any of the team are there from Newcastle today. But it was a fascinating article, and I thought, oh my goodness, why am I not doing this in practice? So I felt quite strongly that I should probably do something about it. And as you know, all our patients end up having some kind of respiratory weakness. And breath-stacking is a very simple way to try and get some air into your lungs. And as Judy mentioned earlier, there's the NICE guidelines in 2016 that mention it. And there's a number of other papers that now mention it. In fact, Rod and I from Australia were trying to remember if it's Nicole or Nicola in Australia who's doing a PhD at the moment, and she should be finished quite soon. And the results from that will be really interesting. She's working with a large group of MS and MND patients and really looking at absolutely everything to do with breathing. So that's going to be really interesting. But when I did the pilot in 2012, there were about 20 papers, and there's now a lot more, so please research it if you don't know much about it. Now, I've asked certain members of the audience to tell me if I'm going off script, and because I tend to tell stories. So if you think I'm going on too much, then please just stick your hand up. So one of the things that can tell an assessment tool if you've got breathing problems is to do a peak flow. Now, peak flow monitor is quite a cheap piece of equipment. And recently, very recently, I checked half my caseload. So it was just kind of a snapshot. And I was actually quite surprised that 3/4 of the caseload had a peak flow of less than 270. Now, at less than 270, the guidelines tell us to start using breath-stacking techniques. And if you notice on the slide, 33% of those actually had a peak flow of less than 170. So that means that they don't have an effective cough. And I'm sure everybody has seen a patient that they've worked with in great distress because they've got a chest infection and they just can't get rid of this awful mucus that's built up in their chest. So breath-stacking is simple, inexpensive, £30 for a lung volume recruitment bag, which I'll show you in a minute. And it can hopefully keep the lungs expanded and lessen distress. Okay, so that's just a picture of it there. So it holds 1.5 litres of air, and it's got one-way valve. And what we would do is we would have a mask or a mouthpiece attached. At the moment, it's got a mouthpiece attached to that one there. But I would generally use a mask as well. Okay. So the basic technique we would teach in the first instance, I would just do some diaphragmatic breathing with my patients. So if you can just think about your own breathing right now, and if you can put your hands up, and an in-breath, are you lifting your chest up? Or are you lifting, are you lifting your stomach up? So when you breathe in, what's moving? So chest, stomach. Ooh, okay, so the stomach wins. Okay. So singers out there will very definitely, if you go and see patients who are singers, they will definitely be completing a diaphragmatic breaths. So, and the diaphragm, as you know, is a big breathing muscle. So we want to activate that. So when I start talking to my patients about this, I would immediately ask them to do some homework, and that would just be to find their diaphragm and actually start breathing with it. And in addition to that, what I would do is ask them to then start to do some diaphragmatic breaths and hold their breath as well. So this is homework, moving on to using the lung volume recruitment bag. Okay, and just to say to you as well, that I guess because we're in Scotland, a lot of our patients, that bag, they actually call it a bagpipe. And I think that's probably because often it's easier for them to put it underneath their arm and squeeze it from there. So it wasn't me that coined that phrase, but certainly we all tend to call it the bagpipe now. And I have to thank the Tartan Association for all the tartans. These are actually Fraser tartans. So there's probably about 25 to choose from, and they allowed me to use the tartans for my slides. So my pilot was completed in 2012 with 15 of my patients. And the physios in the team who helped me were horrified when I decided to include patients without respiratory problems. And I did that because I felt that by the time somebody might have respiratory problems, they might also have lots of other things going on and lots of people visiting. So I thought, well, we had the opportunity, we should help them to teach them how to use the breath-stacking when things were a bit quieter. And 14 out of the 15 patients were compliant, and even if they had, their peak flow was above 270, they felt it was important to use it on a daily basis. And if somebody had problems with expectoration, then they would use it a lot more than that. And in addition to that, we decided in those days, and I have to say those days are gone because now there's a load of information. Doug McKim and his team from Ottawa produce a great website on breath-stacking. And if you're typing in Ottawa, remember that Ottawa is O-T-T-A, not O-T-T-O. He's not here just now, but I believe there is some member of the team here, and they've done a lot of research on breath-stacking, but also have a lot of stuff for us to look at. So at that time, I produced a patient leaflet, a letter to the GP with evidence, a pathway, which is in the next slide, an assessment form, and in that assessment form, I thought it was important to think about carer burden as well, and the ability to use the lung volume recruitment bag. I think because of the pilot, we decided just to implement it and start using it in everyday life. So this is just an example of the draft pathway that we produced. And then I've been asked by the organisers, unfortunately, my research has hit a few bumps, so I'll tell you about the research just before the end that I'm hoping to do next year. But I've been asked by the organisers just to talk about the models that I used to introduce breath-stacking, because it wasn't used in my area in Scotland. So this is quite a busy slide, so I'll just talk you through it. So I've already said that when I'm introducing breath-stacking, I ask them to do some homework to start with, so just some breathing homework. And as well as that, I give them a breath-stacking leaflet. So they've got even more homework, because then I ask them to breathe in fully, feel as though they're really filling their lungs. And I ask them as well as that to hold their breath and to breathe out slowly, or if they've got problems with their mucus, then I ask them to huff, so kind of huff it out. And then, as well as doing that, I felt it was really important to get the rest of the team involved. So what I would do is I would phone the physio and the speech and language therapist. Speech and language therapist teaches breathing techniques to begin with. And not only that, they know about glottal control and they know about stuff that I don't know about. So, and I would also introduce the physio. So we would do a joint visit with the person with MND, their carer often, the physio and the speech and language therapist. And that may seem like a lot of people at one time, but it then means that I can do an education session on how to use breath stacking. And with the physios, they maybe never seen it before, but they get the hang of it really quickly because they know the you guys know the background information on it. So for you, just doing it once. And the other thing with having the team is that the speech therapist can say to me, oh, well, this person isn't going to manage to hold their breath. Or the physio would say, oh, well, I would like to use this visualization technique. So I'm always learning from them as well. And the pros of using this method, of this model, is that everybody gets trained in breath stacking, but not just that. Because I'm at the same time completing a respiratory assessment form and maybe highlighting some issues that maybe it's important for the patient to look out for, then we've then got the physio who can come in and start thinking about, are they lying flat, how many pillows, are they waking up more frequently, and the speech therapist too. So we've then got, with this model, 3 different professionals coming into the house that can just check technique, make sure that they're actually breathing fully into their diaphragm, and ask the questions about their respiratory issues. In the second model, in the neighbouring health board, I was actually asked to go down and do a talk to about 30 physiotherapists and 1 speech and language therapist. And from that, there was a physio that wanted to take this on, and she's kind of become the breath stacking champion. And what she's done now is she's just adapted the talk and she's run with it. So I'm just quite interested to see how that goes and whether it has been implemented. You girls there are yes, no? Half and half, okay. I would say probably in the area that I work in, I would definitely say that it's been implemented into practice. And the physios have gone back to their physios and talked about it, and the confidence has increased. So, if I see somebody newly diagnosed with breathing problems and they've already got a physio involved, then somebody will say to me, oh, and I've got this weird bagpipe thing that I use. And that's great because it just shows that the models actually worked. Okay, so part of my 2019 research will be to look at the models and how to establish the treatment method into everyday life, into everyday practice and treatment. So the Scottish Government, as Judy said already, invested heavily in the clinical specialist team. So this gave us the opportunity to do lots of research and moving forward and increasing care for this, this group of patients. Some of you will have heard of the Joanna Briggs Institute, and it encourages meaningful, appropriate, and effective documents to be produced, and most importantly, to be disseminated. And I went on their training, which is quite an intensive week-long training, but they teach you in 10 types of different reviews. So similar, probably people have heard of Cochrane, so similar to that. And out of that, what I really want to do is collate as much of the information about MND and breath stacking as possible. And I'm finding that it's really easy to find the hard literature, but the soft literature is much harder to find. So I'd like to collate what you do, or what your colleagues do, or what your departments do, because there's a lot of very, very helpful and valid information out there that's used in small areas. And what I would like to do at the end of 2019 is produce a map, a scoping review of what's out there, so we can get some consensus. And I'll put up my email address at the end. Okay, so the other thing is, Gordon Aikman was mentioned earlier on, an amazing visionary, and what he has offered is, I've got scholarship to work for the next year part-time, just looking at what is it that professionals need, and what is it that patients need. So is it training, equipment, protocols, safety information for sure, when to stop it, and when not to start it at all? Do they need template forms to use? To adapt? Do you just need to know who the experts are in your own area? Is it video postcards, so when the person goes into hospital with the equipment that the nurses know how to use it? Or a dedicated site where all the information can be drawn and pulled together? So once the data, my data, has been collected and analysed, I'm going to hopefully produce a package of solutions to whatever the problems are. So this, together with the scoping review, I hope to make a rounded piece of work so that I can produce something that is of practical value. Can I finish by offering thanks? There's lots of people I'd like to thank, from the Australian and Canadian counterparts who's really helped me, to the clinical specialist team, and lots of other people. Apart from anything else, the Performa that Judy was talking about earlier now has a section in it so that I can know when people are started and on breath stacking from the clinical specialist team. So, that kind of data is going to be really helpful for me in the future. So, and that's my email address again. Thank you.
Are there questions? There's a few.
Thank you. That was a great presentation. Emily Plowman from University of Florida. Are you able to share with us from your experience what your treatment program looks like? For example, how many repetitions and how many sets throughout the day and the timing of that?
Yeah, of course. If usually patients prescribe it themselves, what I didn't mention was that there's emerging evidence to show that breath stacking can help with the swallow as well, and I believe there's a presentation later on which will be really helpful from talking about music therapy as well, and the role it has to help with swallowing. So if somebody was having problems with their swallow, I would actually suggest, if they wanted to try to use it just before they have their meal. If somebody's got a cold or a chest infection or is really gungy in their chest, I would say use it however many times you want. But I would also say that my personal opinion is that don't use it just before you go to your bed, because if you're then moving mucus about and then going to your bed, you'll end up just coughing overnight. So I would ask them to do it 4 times a day, but it's really up to them.
And I really like that you included patients whose peak cough flow was actually greater than 270 in a more prophylactic manner. We've started doing that for other therapeutics, and we've felt that it's been pretty empowering for the patient and beneficial. Did you see anything specific in those individuals?
That's great to hear that. And I think we might, I mean, that hasn't really been looked at, but I feel myself that it's therapeutic. And I wonder as well as if the peak flow might be therapeutic as well, and there's no evidence at all. But I mean, we've had one gentleman called Bill who actually sent me before this talk, and I thought I wouldn't have time to speak about it. He sent me his peak flow readings for twice a day he was doing them. So that meant twice a day he was filling his lungs fully and expelling it. And I had the measures which showed that he's much better in the morning than the afternoon. And I find that with the patients who do measure their peak flow every day, that's exactly. So, you know, I wonder if, and they both got peak flow of about 450, 500. But for them, they feel it's therapeutic.
Thank you.
Thank you.
I think we actually have to move on.
Okay.
Thank you very much.